Please feel free. My name is Courtney Seaborn with Terra Health Plans. Happy you guys are all here today. I'm here to introduce Dr. Annie Williams, our guest speaker today. So, Annie Louise Williams, MD, FACOG, Fellow of the American College of Obstetrics and Gynecologist, is a board-certified obstetrician, gynecologist, and dedicated advocate for women's health. She currently serves as a Deputy District Health Director for Norfolk Health District and is a senior physician, CEO, and owner of Contemporary OBGYN Associates Ltd. Dr. Williams completed her medical training at Eastern Virginia Medical School, where she also served as chief resident in obstetrics and gynecology. Throughout her career, she has held leadership roles at Centera Southside Hospital and Bon Secours DePaul Medical Center, including medical staff president and chair of the Continuous Quality Improvement Committee. A respected educator and community leader, she's received numerous honors for her contribution to public health, and medical education. Dr. Williams is also an active speaker and mentor, partnering with media, healthcare organizations, and community initiatives to promote maternal and child health. Thank you so much for being here today. I'm going to open it to you. We have people that are virtual. Please feel free to unmute yourself for questions, and I'll be here for you.
Thank you.
Thank you.
Great introduction. Good afternoon, everyone.
Good afternoon.
I'd like to thank the consortium and all its supporting, all of its supporting organizations for this event, which at this particular time is just so crucial. My topic is improving birth safety for Black families, strategies that work, subtitled, How Not to Be a Statistic. I'm going to give you a different slant on this. I have two time-proven strategies that will work when used. And then I have two cases whose outcomes will help you understand why those strategies work when used. So let me just first go to Google, as many of us do, and see what is meant by becoming a statistic. You'll get a nice AI-driven response that is usually comprehensive. And the first thing it lists is, in bold letters, dehumanization. It then goes on to say the phrase suggests that when someone becomes a statistic, their individual story and suffering are reduced to a number, and their unique identity is lost in the broader context of the problem. We're all here today because of the broader context of the problem. When you look at pregnancy as a condition, it's as normal could get. I mean, how else are we going to perpetuate the species and prevent humans from becoming extinct? So why now, in the most modern and technologically savvy time in our history, are we seeing an increase in maternal deaths? And why particularly are we seeing them in Black families? So from the start, I'm going to tell you that the two strategies, the first is don't labor alone. And I'll expand on that. The second is find your village. The term, it takes a village to raise a child, comes from an African proverb, and it signals that there's a need for support and collaboration. You can read on the slide how it's listed. There was actually an international conference held in 2018 on the topic of enhancing and understanding the concept of the village. The terms that were used pretty much couched in behavioral medicine theory, not so much in strict medicine and biological terms, but it fits so well in a system that should be family-oriented and that should involve everybody in the village. So when we look at maternal mortality today, we're looking at the numbers, particularly when Black women are described. The references are to conditions, to aspects of the problem, and not to their own personal situations. What is their home like? What is their support system? What are their interests? What are their fears? What are their anxieties? These attempts now to address all of those things is crucial, but it has to start early on. I can tell you from my time in practicing obstetrics that the prenatal part of pregnancy is just as frightening as your time in labor. I actually remember saying to myself when I learned I was pregnant, I'm gonna die. And the reason I said that is because at the time, it was said that doctors, nurses, and doctors' wives were always the ones that suffered complications. And I thought, oh my God, it can't be. But it's a time of anxiety. It's like asking somebody who's never played football to go out onto the field and score, or somebody who's never cooked a meal to go into a restaurant and prepare a five-star meal. So being pregnant is not something that comes naturally for everybody, and the outcomes are often impacted by who is surrounding them and who they can reach out to when they feel anxiety and fear. So their individual stories are crucial. The fact that they are considering that it's going to be an event that brings about some level of suffering is crucial for all of us to understand. Most of the studies are focused on the postpartum period, but the early part of pregnancy, the time during labor, the time during delivery, and the postpartum period are all fragile times. So this conference that was convened looked at behavioral theory. There was a sense that children who had handicaps or disabilities of one sort or another posed additional challenges to families. And so a model was created that put the child at the center and looked at which supporting structures, groups would bring about the best outcomes for that family and handling the challenges for that child. In this schematic, I'd like you to think of the pregnant mom as the child. And then look at the surrounding structures, parents, caregivers, siblings, crucial, but it doesn't have to be your biological family. For many, your village includes people that you have spent years in college with, that you trained with, or that you have met because of your social activities, extended family, friends, and neighbors. And then there's school, community, religion, outlet service, and the practitioners themselves. The other part of the strategy, in addition to finding your village, is being alone, not being alone. Don't labor alone. So this book by Dr. Murthy has some important insights about how the pandemic affected us when we were separate one from the other. Great, thank you so much. And this is one of the quotes from his book. What he learned from his research of over 250,000 people, and it was said to be 148 studies. And I quote, "The impact of social connection on reducing lifespan is equal to the risk of smoking 15 cigarettes a day.
Good Lord.
And is greater than the risk associated with obesity, excess alcohol consumption, and lack of exercise. Simply put, the impact of lacking social connections can be a significant danger to your health. The other thing to consider is that CDC says 80% of maternal deaths are preventable. So what are we doing with all the technology and inventions that we have to approach a preventive strategy rather than a therapeutic strategy? Most of the complications of childbirth can be treated. So they're not in and of themselves necessarily markers for death. Preeclampsia is treatable. Pulmonary emboli are treatable. Even amniotic fluid emboli. Early detection is the key. And early detection means not leaving that mom in isolation, making sure she's supported, making sure that she has people around her that she trusts. So the two case studies that I'm going to present are going to help to amplify the importance of those two strategies. The first is that of a 32-year-old Black female primary gravid. Her EDC is unknown. We have no record of prenatal care. Her maternal blood type and other lab results are not known. She, at the time of this assessment, was 5'9" and weighed 96 pounds. Her pre-pregnant weight, however, was 128 pounds. So the questions are, was she having hyperemesis gravidarum? Was she so depressed that she couldn't eat? Had she developed some condition that would cause this degree of wasting? What would be the impact on the baby? Certainly you'd expect some growth restriction. None of these things are entered in the information we have. The report on this particular case indicates that she had told friends that she did not want to deliver her baby in a hospital and that she did not trust hospitals. She had no significant medical history. Her social history was otherwise unknown, though there's no mention of her family or of her family history. She has a career as a professional athlete. This patient was found dead in her apartment after someone reported not hearing from her in 3 or 4 days. Who leaves a pregnant woman without reaching out for 3 or 4 days? The coroner's report is very sketchy. And I think it looks at those numbers and issues that are sometimes so peculiar to how they like to explain the outcome. They reported that the toxicology report was negative. Why would you expect a world-class athlete to be involved with drugs? They gave no indication that she had had a seizure. There's no indication that her lip was bit, that her tongue was cut, or any signs of being post-ictal, but they concluded that she passed because she had an eclamptic seizure, then suffered respiratory arrest and died. They also said that she died in labor based on the fact that her infant was crowned up when they found her on the bed. Can you imagine how she suffered? How tragic is that? Had someone been with her, had she not been alone, this baby and this mom would be alive. There's no doubt about that. If she had a village that cared enough about her to check on her morning, noon, and night, to ask if I can bring you something to eat, are you craving anything? How are your visits going with the doctor? Who in the world was she able to reach out to? She needed a village. Her village would have kept her and kept her baby alive. This is the outcome when pregnant moms and Black families don't trust the institutions, when they have limited options. If there was a nursing center, a birthing center that she could go to, that would have been an option. And there was in this community at one time a birthing center at Bon Secours DePaul Hospital. It was staffed by nurse midwives. It was for women who made a birth plan and were able to follow it through. And they were surrounded by other medical professionals so that if at any time the course went off, if they needed because of heart rate changes, which were really checked by physical auscultation rather than by continuous tracing, they would come out to the labor deck, explain to the family that conditions had changed and they needed to be transferred over. Still, options. So that's case number one. You're going to hear more about case number two as we move on. So again, CDC reports and also the most recent Virginia maternal mortality review report also indicates that more than 80% of maternal deaths are preventable. And again, what are we doing to prevent them? Other than trying to chronicle what should happen, what can happen. I put this slide up here because the payers are in some way complicit. The compensation system actually incentivizes erratic care. It is best when Black families are with one provider and can continue with that provider to establish a relationship to build trust. But if you look at these different plans, it's like choosing which county you want to go to at a carnival. They're offering dollar incentives to spend for over-the-counter items. They're offering high-risk moms money to buy healthy foods. We have WIC for that. There's already a well-established program that does a good job, both in supporting moms during pregnancy, after delivery, with their babies, and also with breastfeeding. And so there should be a system where the global payer is what's compensated. But if you look at billing and claims, and any of you that are involved in that, I checked today, there are actually 24 different codes you can use to bill for maternity service. Depends on how many visits you've had, whether or not you've had a previous cesarean, whether or not you're having a VBAC, whether or not you transfer to another system. It's designed to be fragmented. And why wouldn't an uneducated, unfamiliar new mom reach out for these kinds of perks rather than for a continuous relationship that builds trust? ACOG has some recommendations for routine prenatal care. It tries to address demographic characteristics, social needs, psychological needs, and some of the material needs of the family. There has been, as this slide says, a one-size-fits-all model since the 1930s. We are all so different. Families are different, birthing persons are different, situations are different. We need alternatives. If you go to this website, you'll see a great deal more on what ACOG is trying to do to offer some alternatives. In fact, there's one question that I pulled up. This is a scenario of a mom who had an uncomplicated pregnancy, no, quote, risk factors, and she had been told what her prenatal schedule of visits would be. Her question was, is there an alternative? And she was given alternatives. Telehealth, telemedicine as an option, because she said she had to work, and driving in to the office from her work took her over half an hour. So she was given some options, and I think those are the kind of options that practices have to consider. Some telehealth, some home visits, and certainly the option for care in the community. Home births are still legal in the state of Virginia, and there are certified midwives who are delivering them. When I was in practice, we'd always want them to notify us so that we would be on alert if for any reason that patient needed to be transported to the hospital. If you look at the different conditions that are said to be more prevalent in Black families, again, these are all treatable conditions. Hypertension, gestational hypertension, diabetes, even lupus. You know, we have ways of monitoring the baby. We have ways of delivering babies at the appropriate time when there seems to be a negative impact. Phospholipid syndrome, something we've learned more about as a cause of multiple losses. It's not always the case that these patients have to be sent to high-risk physicians or to the perinatologist. When I was in practice, I used to co-manage. And so I would reach out to the EVMS team whenever I needed to. I'd make the patient aware that that's what we were going to do so that she was comfortable to stay with me, but also understand that she would get the highest level of care. This is a birth plan. It's one of many. When I was in practice, I would always ask my patients, what's your birth plan? And they said, what is that? I said, well, how do you want things to go when you're in labor? You have options. These are conversations that I think have to be had early on so that they anticipate what's going to happen, what could happen, what their choices are. Pain control is a big question. There are options. There used to be what's called a walking epidural if you got to that point. Some moms don't want an IV. They can have a hep lock. So having options individualizes and respects the person and doesn't address the problem. If they're going to labor, who can be in the room? What can happen? One of my moms said, can my husband deliver the baby? I said, only if he pays my malpractice premium. Those things we don't allow. But I mean, there's just so many options. And when you consider that at the start of the century, these are numbers from 1900 to 1920, look at the maternal mortality rate. It was never higher than 9.3 per 100 live births. That was during the time of the First World War. And even accounting for that, these are the numbers. Then you fast forward and you look at the rate in the US compared to other countries that have high incomes. In Norway, can you say zero?
Right. Wow.
The latest data, this is from 2018, the latest data is that their number now is 1.2 per 100,000 live births. But look at the US. It's 22.3 overall, still higher than any of the others. But look at the rate for Black families.
Wow.
It's almost double. There has to be an explanation. Prevention, my theory, is the key. Now we're going to look at case number 2, and I'm making this a presentation that asks you to shift your perspective. And then I'm going to want to get some responses from the audience, because I think right now all of us have to contribute. We have to change the climate. We have to provide more options than are currently available. So this is CY. She is a 31-year-old primogravida who noticed clear discharge in her second trimester pregnancy. She reached out to her doctor's office. They addressed the complaint, evaluated her, and saw that her cervix was dilated. Her pregnancy had otherwise been uncomplicated. She was sent to the hospital. She was given betamethasone to help accelerate the maturation of the baby's lungs. They tried tocolytics to delay labor. Things settled down for a bit. And so the plan was to discharge her home on bed rest.
Oh.
Her village said, no. She has to go up 3 flights of steps to get to her apartment. And then she didn't have a maid, a chef, and a butler, so she can't be in bed at rest for the next 20 weeks. So it's a good thing that they did, because later that night, she began contractions and she had a cesarean section. Her son Ellis was born at 1 pound, 10 ounces, 25 weeks gestation. He remained in the NICU for 3 months. He was visited daily, had kangaroo care. Mom pumped her breast milk for 4 weeks until having to go back to work, it dried up. And then Ellis received donor milk throughout. Thank goodness for the milk bank. Ellis went home after 14 weeks and celebrated Thanksgiving with his village. This is Ellis on the left at birth, 1 pound 10. And this is Ellis now.
Cute.
An active, healthy, loving baby boy. So at this point, I welcome questions and comments, but I again reiterate the 2 strategies that are going to work. Do not allow a Black mother, a Black family to be alone. Connectedness is so important. The second is when the family learns of pregnancy, establish the village. My children have 5 aunties who my mother did not give birth to. Because when I was pregnant, my best friends were pregnant with me. There was not a day that I didn't get 5 calls from each of them. Are you craving something? Are you gaining too much weight? You know your hips are too big already. But boy, was that comforting. Even as I was marshaling through, and some of the ladies in this room remember when I was working while pregnant and delivering, but still I had the comfort of knowing that I had that village that I could fall back on, in addition to a fairly large and loving family. So connectedness, social connections, the fact of being alone as being a risk factor itself, please consider that. And then if you see someone who seems to need another member of their village, you have knowledge, you all are passionate about what we do, reach out and see if they would like to have you in their village. Thank you guys for your attention. I welcome questions at this point.
Question over here, so I can do the virtual thing where I say questions there. Any questions?
That's good.
I do.
Yes.
Hi, I work for Centera and my role is to help educate all of the new nurses to women's health, new graduates, at all the Centeras across the system. And so what I'm teaching them, we're a little bit past some of this point, right? If you happen to find a mom who doesn't have people supporting her, or perhaps they're out of town and they don't have people eminently available. What kind of strategies might you recommend for a nurse who is presented with that situation? To where the patient was already actively in labor and delivery and maybe didn't have some of that pre-planned out?
Well, you know, the idea would be for the support to come early on, for a patient to reach and then be introduced to essentially a stranger. It is hard.
Yeah.
I used to encourage my patients to take hospital visits. So they know the hospital they're going to deliver at. I'd encourage them, and I'd encourage your nurses to walk through. And if there are any parents, Centera used to have OB tours.
Yeah.
I hope they still do. I
They
think
finally came back.
well,
The
that's
COVID
important.
lull. Yeah.
And they should occur early in pregnancy as well as late. When I was in practice, it was typically in 3rd trimester when they were just trying to see where to go, where to check in, and it was procedural. But there are faces that you connect to. There are some people whose energy is so wonderful that you immediately, and you go back and you say, what was your name?
Yeah.
Yes, ma'am. And then you look for that person. And sometimes just seeing that face is enough to give you confidence and to take away your anxiety. So I would suggest early relationships and continuous relationships. You know, the issue of this kind of patchwork care is all wonderful technologically. And I'm sure the credentials for everybody that's offering to deliver it is fine, but the relationship build over time.
I mean, can I take you back real quick? So also lean on the nurses that are there. We have people that come in all the time and don't have support. But the nurses that are there will instantly, one will become your mama, your auntie, and we all just lean into that patient. And also, so for Norfolk General, we have I'm big on Village. This like hit my heart because there are partners that are already within our hospital. And if they make a call, I get a lot of calls and we reach out to them and they come in and step in and support. So even though sometimes they don't connect for whatever reason, afterwards, we make sure before they leave that they are connected and plugged in and there are people to surround them. And they have cards and numbers to call so that they can stay plugged in. Lean into your nurses that are there. They know how to get the right support people there.
One thing that, because a lot of my new graduates come into Norfolk General simply because it's the biggest hospital, right? We also have the Obices and the Albemarles that are more rural, that don't have quite as many resources. And I have those nurses who come in through too, and so I'm not as blessed to have a chair seat at every single one of the hospitals, right? But as much as I would love to copy and paste.
So I'm gonna steal again, I'll steal this one. Yeah, I was gonna say, there's a community, so I meet with the different FMCs throughout. And so we all share the community resources that are happening in here, right? So everybody's kind of plugged in and know, hey, Terry, I'm over at OBC, can you help me out? And I've done the same, hey, at OBC, hey, I need this, can you help me out? And the same with Lee. So we're all kind of trying to figure out how to work together so we
Yeah.
can keep that village together. Okay,
Yeah, that's
yeah.
important.
Can I piggyback on it also? In this area, multiple home visiting programs where a nurse can go out to the home or a mentor. So how about we share that information with you after the presentation?
I got one question over here, sorry, hands raised for a while.
That's okay. I was actually given, I know some of these ladies with home visitation. I work at Chesapeake Health Department Baby Care Program. And we've been trying to really get our OB docs to understand that we just do great things. We're not gonna contradict them or do anything of the sort. We just want them to have the information because it's 100% that relationship. And you have to build a relationship. It doesn't happen, as we all know, within a few moments' time. And so before mom gets to be in labor, upset, or has so many issues on her shoulders, that we can, help her out and give her that support, and she can call all the time. I have my little blue phone with me 24/7. So, and by the way, thank you so much for this talk. It was wonderful. This is just great. It's so great to be with you, Dr. Williams.
When I was in training, we wanted medical students and to come to our offices to see some of those stages and see what is needed to connect with those families. So I think training programs now have to change to where they involve students earlier. Most institutions are asking for interns. We have some internship programs at the health department where we focus mostly on preventive health. But, we have children and moms that we serve all the time, but it's important for everyone in training to see every phase of the process.
I wanted to say, excuse me, one more thing is that birth plan that we were given a little earlier, and what you just referenced as well, is that toward the end of it.
I was gonna say, yeah, Is he here today?
To add,
Hey, I'm gonna try to meet you.
Looks like he's got somebody with him, probably his wife.
okay, that's okay, it happens. But to have somewhere in that plan is, who can I rely on besides a home
He
visiting
reminds
nurse?
me so much of Mr. Reed.
Am I gonna have? How about my
They could be
transportation?
brothers, man.
Maybe another one, and I've got all these car seats to carry, and I have a brand new baby in the building.
Really?
Help me. For this baby earlier than not is so important.
Real serious. Oh my goodness.
We hear you, Sally. Sally. Yeah, thank you, Sally. Mute yourself. There you go.
There she goes. Sorry about that.
Yeah, thank you.
I'm with the Portsmouth Health Department. What strategy can we use? Because
Yeah.
there's no birthing center. Well, I take that back. There's a birthing center in Portsmouth. But there are no physicians attached to that center. Women in Portsmouth and teenagers are going full term with no prenatal care. What strategies can we use to encourage prenatal care?
Well, you have to partner with the area health systems. When I was in training at Portsmouth General Hospital was still there, the residents rotated through the hospital. There are enough OB residents, I believe, in the region, not just with Centera, but also with Riverside Health System, sometimes BCU sends OB residents. And when I was in training, Howard University in Washington would send physicians to the hospital. And seeing a face that looks like yours is important. If you don't think it is, it is.
They can't go to Maryview. There's no birthing, well, they have
a building.
they have a building, but there's no birthing center.
Well, there has to be a campaign for the community to understand that care is available, but it's not going to be 15 minutes away. That's why our networking, our connections, and our collaboration are going to have an impact. It's a preventive strategy. You can't just wait for women to get to term having had no prenatal care. I mean, it's possible to put a pop-up in the health department. It's possible to have OB residents come and do prenatal care. Health department used to do that all the time. So there has to be a strategy, I think, and I think this is one of the things that I'll certainly take back to VDH. But you have to have the care available. And there may be some women who don't want to deliver in the hospital and who don't really want to see a person face to face. Telemedicine is a very legitimate method for medical care. I think that should be an option. I think asking women, well, what are you comfortable with? What are you thinking? And if they give you the TikTok version of what they think their delivery should be, over time, when you deliver and develop a relationship, you'll be able to tell them, well, that might be possible at a different time, but not right now. So let's look at some other options. But I think it's all about opening up the conversation and really addressing the problem for the individual, not looking at what are the risk factors. Does she have hypertension? Is she overweight? Oh, she's going to get preeclampsia. Those are numbers. That's what the statistic does. It overlooks the person, makes that person a number, and then forgets about the overall problem. And I think we have to stop doing that.
And Dr. Williams, I also wanted to make sure I address the people in our chat as well. So thank you guys for being virtual. We have Lachelle says, thank you so much. I am a survivor of pre-E ×3 and HELLP. I believe that early interventions of my midwives, doulas, and EVMS MFM team made a difference in the life and death for me and my babies. Also, Kayla said, I would love to get information for home visit from nurses as a CHW.
Community health work.
Yeah. See a variety of people and cases. So that is great. And also I've put in the early impact of Virginia. And I wanted to ask if anyone in the chat had any questions before we move back to the room.
Let me just say, I hope one of the things that comes from this consortium is that you develop a resource list. All of you should know each other and be able to reach out because you have services that are going to benefit every family, not just Black families.
Yes, ma'am.
Dr. Williams, I haven't been a nurse and been with you and knew you when you were in practice at Newton General, and I was a scrub nurse there during your time. I have always been admired by you and the care that she has given her patients one-on-one. It was outstanding. So I give you kudos and say thank you for all you do. Having been a nurse in labor and delivery postpartum and having worked in the OB/GYN with a lot of the doctors back then that was through EVMS, High Hall and all that. My thing is, and I too live in Portsmouth, so it does hurt me that we don't have the birthing center at Maryview is beautiful, but it's been closed for a while. And the fact that we don't even have OB doctors in the city of Portsmouth as a nurse is overwhelming to me, and it's been something that I have for the last 5, 6 years probably cringe. But my thing is, how can we reach, my dream would be if we can have some type of, okay, I guess community health worker in the OB offices, because I found out, having been a nurse, the earlier you can reach these young people and pregnant moms is doing prenatal. And because a lot of times, having been, now I'm a home visiting nurse, and for the doula service, having been through that training, you get them when they're late in pregnancy, about to deliver. And they miss out on so much education and support and guidance. My thing is, we really need to connect with these OB doctors to try to get them there at that point where you can build that rapport, you can build that village versus you seeing them. I know a lot of times now we get them in the hospital. Well, you want to get them before they get in the hospital. You want to be able to work with them so you can go over the birth plan. So as a nurse, you can go over them with the expecting with labor and have all that education. But when you got them already 39 weeks laboring, all that you could have done to prepare them mentally and emotionally, you lose that time because they're ready to deliver now. So I just feel like, and like she said, in Portsmouth, a lot of our Portsmouth moms are not getting prenatal care. They're just showing up. And to me, it's disheartening, because even trained as a doula, you want to be able to go through the different exercises and the different things that you can do to prepare them, but you don't have that time frame, because by the time you see them and they get your information, your resource, it's like you're ready to deliver.
That's
And
a
so that is a drawback. I
part
don't
of
know.
that is a legislative problem.
Mhm.
If the city of Portsmouth wants to have OB care, it can afford it.
Yeah.
It can
It's
afford
a
it. The cha-ching, they can afford it. So we all need to make our legislators understand the need. And we need to continue to pressure. We need data to show that these are women, healthy women, who should have been in prenatal care, but had no access, and this is what happened. So, I mean, at this point, one of the other things that the consortium can do is collect the data. Show them how many of your Portsmouth residents ended up having to deliver elsewhere, and let them know obstetricians are not the only persons capable of delivering. If you put a nurse midwife in that center and had an obstetrician to back them up, that would probably be more than ideal for the average, what's called low-risk client. So again, we have to look at the options that are still safe, but are indeed options. But that's a legislative issue. You know, we are trying to make this region understand that we don't have to be separate little municipalities. That if we function as a region, we'll have more impact. So all of us have to advocate and speak up.
I want, we have 5 more minutes, so probably have enough for 2 more questions.
Had her arm up for
Well, I'm glad you mentioned that about having another option, that OBs are just not the only option. I'm a doula, and I really believe as long as you are low risk, then you can birth at home, outside of the hospital. The hospital is not, I know that it's the most popular choice, but it's not the only choice. Also, piggybacking off of you guys earlier when you were saying about getting the resources together. So maybe at the first visit, I don't know, the OB office or whoever they're seeing for prenatal care can have a list of those resources for doulas or whoever they need to refer the client to or the patient to, so they can reach out to those people right then, at the beginning of the pregnancy. So we're not waiting till the end and, you know. all-
There's a disparity there too, because we have a lot of our baby care and CHIP and any other home visiting program in those offices. And then I'll ask them, didn't your doctor give this to you? No, they never said anything to us about, it's like, I just handed you this cute little package of all this good stuff for all the home visitors. We're not in competition. We want doulas. We just want everybody to be serviced. And so it's frustrating because sometimes it's, not you, Dr. Williams, God knows, but it's sometimes the OBs, I think shuffle it under some other papers, they give them 50 million and then out the door they go and they don't know.
Satellite offices can be set up as well. That's another.
Yeah,
Type of take.
Dr. Williams was open to that. I've talked to him a good few times, so, but he's just one.
We have two more. I'll probably go behind shut hair reads for a little while. Hi.
Hi, I also work at Portsmouth. I work at the clinic, the nursing supervisor at the clinic, and we are trying to set up to have an OB come in once or twice a week. We are not being very successful in finding an OB. But we're also working on a grant so that we can at least get these women transportation. There's a huge transportation issue in Portsmouth as well to get, especially since we don't have the, facilities for these women to go to. So there's a huge, they have to go 15, 20 minutes, in his car ride, and not everybody has that option. So we're also trying to work on transportation, but we would love to have an OB come to our clinic if we can get one.
Yes, ma'am. Are you the OB?
I am the midwife. Yeah, the midwife. I have to say this because I have been trying to get a building. I found a building. I have gone, look, the birth certificates that are happening in Portsmouth are happening through my practice and other midwives who are doing the home births because we don't have a place. And even looking at trying to invest in a mobile unit that can go into the city and see people. But, for me, when I looked at this building, it would have been $1 million investment for me to invest in a city that doesn't have these options. So for the health department that says we want somebody, we have a team. We'll come and we'll see those patients. If, so I'm putting all of y'all on notice if anybody wants to help. Yes, but if you're willing to do it, listen, that's one of my team. How do I talk about Portsmouth? All the time.
All the time.
Because that's our priority and we want to do it. But, we have the village, we have that we're building this infrastructure so that we can have those services in a city that needs it the most.
I just wanted to say one thing. There's a Dr. Michael Kopek,
Yes.
family medicine, but he's trained also in obstetrics. So, and he is able to deliver, obviously not there in that building, but he would be somebody that you all could partner with as well, because he's seeing these mothers and, it would be a good synergy.
Kopek.
Yeah.
I will say, this would be great to continue the conversation. It is 1:00. I saw your hand raised. Sorry.
Just a real quick comment. I just think that, we have to break out of the mentality of operating in silos. And if we are expecting, community, we're talking about community, then we have to be able to operate as a community. The hospital is a system, but then there's also the community and their community health workers, doulas, professionals, birth workers, that there needs to be an environment that they can work cooperatively together so that we can move these mothers and birthing people into whatever care is needed. I think the breakdown comes with trying to access another system and another system and another system, where each system has its independent barriers, and silos. And so we have to operate within a system of community as well. That's all I wanted to say.
Thank you. I think that's a good place for us to close. Thank you guys so much. Thank you. Hopefully we'll continue the conversation. Have a good day, guys.
And look, Terry, I wanted to.
You can have a good day as well.
Great, but I.